Welcome, colleagues, and thank you for taking the time to engage with this lecture. Today, we'll be focusing on evidence-based approaches to fitness assessment and exercise testing. Our work as public health professionals, educators, and practitioners is shaped by the responsibility to promote physical activity that is safe, effective, and grounded in science. Whether you're designing a community-based wellness program, conducting clinical screenings, or working within a school or rehabilitation setting, these ACSM tools are foundational to how we assess risk, prescribe activity, and monitor change over time. In this lecture, we'll be exploring evidence-based approaches to cardiorespiratory fitness assessment guided by the American College of Sports Medicine's guidelines for exercise testing and prescription and fitness assessment manual. These frameworks offer a comprehensive lens through which we evaluate health, risk, and functional capacity, particularly in populations that benefit most from structured physical activity interventions. But before we get into protocols, I want to pause and ask a foundational question. Why do we measure cardiorespiratory fitness? What does it tell us? Not just about an individual's athletic potential, but about their overall health trajectory. Cardiorespiratory fitness reflects on the ability of the cardiovascular and respiratory systems to supply oxygen during sustained physical activities. It's often quantified by VO2 max, the maximal amount of oxygen the body can utilize, and serves as a highly predictive marker of longevity and disease risk. Decades of research have demonstrated inverse associations between VO2 max and all-cause mortality, cardiovascular events, and metabolic disorders like type 2 diabetes. In fact, CRF is now being recognized not just as a performance metric, but as a vital sign on par with blood pressure, cholesterol, and body mass index. It offers clinicians and public health professionals a dynamic view of functional capacity and systemic resilience. And unlike some biomarkers that are influenced heavily by genetics or medications, CRF is modifiable. It responds to behavior change, making it not only a diagnostic tool, but a strategic lever in health promotion and chronic disease prevention. Measuring CRF is particularly critical when working with individuals across the lifespan, from adolescents navigating sedentary habits to older adults managing hypertension or osteoarthritis. It helps us tailor interventions that are meaningful, realistic, and safe. When done thoughtfully, these assessments allow us to reduce health risk, guide exercise prescription, and monitor progress over time. But the value of CRF assessment also extends beyond the individual. When aggregated across groups and communities, these metrics support population-level surveillance efforts. The data helps us identify disparities, evaluate program outcomes, and inform resource allocation in underserved regions. In this way, CRF isn't just about fitness, it's about equity, policy, and resilience. So whether you're preparing for a clinical screening, designing a community-based wellness program, the tools we'll review today are grounded in science and centered on safety, ethics, and inclusivity. The ACSM's structured approach equips us not only to measure fitness, but to advocate for systems-level change rooted in evidence. Before initiating any exercise testing protocol, one of the most important responsibilities we carry as practitioners is to assess risk in a way that protects individuals and honors evidence-based standards. The American College of Sports Medicine provides a structured algorithm for pre-participation health screening. This algorithm integrates several critical factors: the individual's current physical activity level, the presence of signs or symptoms suggestive of cardiovascular, renal, or metabolic disease, and known chronic conditions. It also considers age, while not a risk factor in isolation, can amplify risk when combined with other health indicators. Why does this matter? Because the goal of risk stratification is not to limit physical activity, it's to protect it. It helps ensure that exercise testing and prescription are both safe and appropriate for the individual's current health status. Rather than relying on blanket recommendations or exhaustive medical exams for everyone, the ACSM approach helps us efficiently identify who needs medical clearance before proceeding and who does not. For example, an asymptomatic adult who exercises regularly and has no known disease generally does not require medical clearance before engaging in moderate or vigorous physical activity. But for someone who is sedentary and experiencing chest discomfort or has a history of myocardial infarction, referral to a healthcare provider is essential before testing begins. This system is especially powerful in community-based settings, where we often work in groups that vary widely in age, background, and access to care. It allows us to tailor our screening strategies, not just to meet clinical standards, but to reduce unintentional harm among vulnerable populations who may already face barriers to safe physical activity. It's worth noting that the ACSM model is also designed to enhance autonomy and reduce unnecessary burden. By moving away from older models that required automatic physician clearance for many individuals regardless of symptoms, we now follow a path that balances practicality with ethical diligence. From a public health perspective, using this framework across diverse populations strengthens both screening validity and program integrity. When we stratify risk properly, we improve the accuracy of our fitness assessments and ensure that downstream interventions, whether clinical or behavioral, are built on a safe and inclusive foundation. In short, risk stratification isn't just a technical step. It's a reflection of our commitment to safety, equity, and responsible practice, and it's the cornerstone of any ethical and effective cardiorespiratory fitness evaluation. Cardiorespiratory endurance, muscular strength and endurance, flexibility, and body composition. These four domains form the foundation of health-related fitness. They're not just physical metrics. They give us a structured way to understand how the body functions, adapts, and carries risk across different populations. Cardiorespiratory endurance, which we often assess through VO2 max, reflects how efficiently the body uses oxygen during sustained activity. It's directly linked to long-term health outcomes, things like cardiovascular disease, hypertension, and type 2 diabetes. What's powerful about CRF is that it's modifiable. Meaningful improvements can happen through targeted interventions, and tracking this over time offers both clinical insight and public health value. Muscular strength and endurance matter for day-to-day function, lifting, climbing stairs, maintaining independence. These aren't just performance outcomes, they're protective. Lower strength levels are associated with falls, decreased mobility, and increased risk for disability in older adults. Including these in assessments gives us the chance to intervene before functional decline happens. Flexibility tends to be underestimated, but it plays an essential role in joint health, mobility, and injury prevention. It also has particular relevance when we're developing inclusive fitness programming for individuals with chronic pain or postural limitations. From rehabilitation to adaptive fitness, flexibility deserves more attention as a marker of access and autonomy. And then there's body composition. More precise than BMI, it allows us to look at visceral fat, lean mass, and metabolic risk with a clearer lens, particularly in public health. It helps us understand disparities that traditional metrics might miss, especially when working with diverse racial, ethnic, or age groups. Each of these domains feeds into how we prescribe exercise for individuals, but more than that, they inform how we understand population level health. These components show up in surveillance tools like BRFSS and NHANES and help us evaluate the reach and impact of community-based programs. They connect physiology to equity, to systems, and to the kind of change we want to see in practice. When we assess fitness through this lens, we're not just collecting data, we're building framework for ethical care, prevention action, and long-term resilience. When we talk about the importance of fitness assessments at the population level, it's essential to understand where our surveillance data comes from and how it's used to inform public health priorities. Two major systems lead the way in the U.S. BRFSS and NHANES. BRFSS, or the Behavioral Risk Factor Surveillance System, is administered by the CDC and is the largest continuously conducted health survey in the world. It collects self-reported data via telephone interviews across all 50 states, D.C., and several territories. Each year, BRFSS gathers input from over 400,000 adults, tracking behaviors related to physical activity, nutrition, smoking, alcohol use, mental health, and chronic conditions like diabetes and obesity. What's powerful about BRFSS is that it generates state-level data. That allows us to monitor regional disparities and respond with targeted interventions. For example, if physical inactivity rates are disproportionately high in a specific county or population group, public health professionals can use that data to justify funding and shape local programs. It's not just information, it's leverage. On the other hand, NHANES, or the National Health and Nutrition Examination Survey, takes a different approach. This system combines personal interviews with physical exams and lab tests, often conducted through mobile examination centers. It provides clinically validated data on blood pressure, body composition, nutrient levels, and even undiagnosed health conditions like hypertension or insulin resistance. What makes NHANES especially valuable is its depth and precision. This survey helped uncover the severity of lead exposure in children in the 1970s, which then prompted federal regulation. It also laid the groundwork for pediatric growth charts and informed key updates to dietary guidelines. Today, NHANES remains the gold standard for national nutrition and health data. Together, they provide a comprehensive picture. BRFSS tells us how people perceive and report their behaviors at the state level, while NHANES allows us to validate and expand on that with clinical evidence. These systems fuel policy, research, grant writing, and public health programming, and they directly impact how we understand trends in cardiorespiratory fitness, obesity, and chronic disease. So when we build assessments, interpret fitness data, or design interventions, it's crucial that we tie our work back to these surveillance tools. They provide not only context, but also accountability and guidance for creating programs that are equitable, evidence-based, and population aware. Maximal oxygen uptake, or VO2 max, is central to how we understand cardiorespiratory fitness. It represents the maximum amount of oxygen a person can use during intense exercise, which means it's measuring the integrated performance of the heart, lungs, and muscles working together under demand. But beyond the physiology, maximal oxygen uptake is one of the leading indicators of cardiovascular function, disease risk, and overall longevity. Lower values are consistently associated with increased risk for cardiovascular disease, hypertension, and type 2 diabetes, and it's one of the few markers we track that's both predictive and modifiable. That's important, not just in identifying current health status, but in guiding safe, tailored interventions that lead to meaningful improvement. The American College of Sports Medicine encourages the use of cardiorespiratory fitness testing, including direct and submaximal methods of assessing maximal oxygen uptake, not only for athletic performance, but for clinical decision making and public health programming, especially in prevention settings, whether primary or secondary. These assessments help us stratify health risk, personalize training plans, and monitor changes in fitness over time. They offer insight that complements and often strengthens data gathered from more conventional indicators. And it's important to remember that we can measure cardiorespiratory fitness across a wide range of contexts, from maximal graded exercise tests in clinical labs to field-based protocols like the 6-minute walk test or step test in community environments. That flexibility allows us to build programs that are accessible without sacrificing quality or safety. From a public health perspective, we also see the value of maximal oxygen uptake data at the population level. For example, the National Health and Nutrition Examination Survey incorporates elements of fitness assessment to estimate national chronic disease burdens. When these data are aggregated, they help us identify disparities in access to physical activity resources and track where targeted interventions could have the most impact. And all of this brings us back to why we measure maximal oxygen uptake in the first place. It's not just about aerobic capacity or athletic goals. It's about function, resilience, and opportunity. When interpreted ethically and used as part of a broader assessment, This metric becomes a powerful tool for equity-driven prevention and care. It connects the science to practice and the individual to systems-level change. In ideal conditions, we assess maximal oxygen uptake using direct measurement, typically with open circuit spirometry in a lab. This produces the most accurate data, but for many of us working in public health, education, or community settings, that level of access simply isn't realistic. Lab-based spirometry requires specialized equipment, trained technicians, and clinical oversight, resources that aren't always available, especially when working with underserved populations or in field environments. That's where validated field tests and submaximal protocols become essential. These methods estimate maximal oxygen uptake safely and with reasonable accuracy, allowing us to assess cardiorespiratory fitness in ways that are scalable and equitable. Tests like the step test, the 1.5 mile run, and the 6-minute walk test rely on core physiological assumptions. One of the most important is the idea that heart rate increases in a linear fashion with workload. As activity intensity rises, heart rate rises along with it, and we use that relationship to estimate aerobic capacity. These protocols also assume consistent mechanical efficiency and valid effort level, which is why standardization and client understanding are critical. Each method has its strengths. Step tests are easy to administer and require minimal equipment, making them ideal for group settings or first screenings. The 1.5 mile run can be more intense but provides solid data in healthy, low-risk populations. Fixed time walk tests, like the 6-minute walk, are especially useful for older adults and individuals with chronic conditions or mobility limitations. They allow us to gather meaningful data without overexerting or putting the participant at risk. But choosing the right method isn't just about ease or preference, it's about context. Who are we working with? What resources do we have? What are the safety considerations? Are we screening in a gym, a clinic, a community center, or a home setting? ACSM encourages practitioners to align testing protocols with population needs, ensuring that methods are both feasible and ethically appropriate. This kind of tailoring reflects our broader public health goals. Fitness testing shouldn't be exclusive. It should be intentional, inclusive, and accessible. When we adapt our approach to fit the population, we're not compromising quality, we're expanding impact. That means validating non-lab protocols, training staff carefully, and maintaining a commitment to safety and equity at every step. Ultimately, field tests and sub-maximal protocols help us bridge the gap between clinical precision and community application. They allow us to estimate maximal oxygen uptake and track change over time while still prioritizing feasibility, ethics, and meaningful outcomes. And when used thoughtfully, they can serve as a launch point for lifelong physical activity anchored in good science and shaped by the realities of the people we serve. When it comes to exercise testing, what happens before the test is just as important as what happens during it. Pre-test conditions matter, not just for accuracy, but for safety and scientific integrity. These are the kinds of details that might feel small, but they have a major impact on data quality and how we interpret results over time. First, individuals should avoid caffeine and heavy meals at least 3 hours before testing. Stimulants and large meals can skew heart rate responses and affect metabolic activity, introducing variability that we can easily avoid with simple guidance. Hydration is also important, but overhydration should be avoided. The goal is to support performance without disrupting balance. Next, familiarity with the testing equipment and procedures helps participants feel more prepared and reduces unexpected responses. Whether it's a treadmill, cycle ergometer, or step bench, a few minutes of orientation can reduce anxiety and improve both effort and compliance during the test. We also pay close attention to the environment. Room temperature, noise levels, and lighting should be controlled to ensure consistency across sessions and participants. These environmental factors may seem peripheral, but they influence physiological responses, especially when we're measuring outcomes like blood pressure or perceived exertion. Finally, technician consistency is key. Protocols should be delivered in a standardized way, with clear instructions and careful monitoring. When testing conditions are inconsistent, either from test to test or technician to technician, we introduce noise into the data, and that makes it harder to detect meaningful change or draw valid comparisons. So when we talk about pre-test standardization, we're really talking about the foundation of ethical, evidence-based practice. These steps help protect participant safety, minimize bias, and ensure that the data we collect are reliable and useful, whether in clinical care, public health surveillance, or academic research. Cycle ergometers and treadmills offer flexibility depending on physical limitations and mobility. Treadmill tests yield higher VO2 max values for most, while cycle tests are better for clients with orthopedic restrictions. Protocols like Bruce, balk, or ramp designs can be customized based on age, fitness level, and health status. When choosing a cardiorespiratory testing protocol, the goal is to align the method with the individual's needs, risk status, and the clinical or community setting. The Bruce protocol is widely used, especially in clinical environments, and involves staged increases in both speed and incline. It's best suited for individuals who are relatively fit and can tolerate higher intensities. The balk protocol, by contrast, maintains a constant walking speed and increases the incline gradually. This makes it a strong choice for older adults or those who may be deconditioned, allowing for better safety and workload control. Ramp protocols increase workload continuously rather than in stages. These are ideal when using a metabolic cart because the smooth transition provides more precise We can estimate VO2 max based on peak workload or time using regression equations. Interpretation relies on ACSM norms, adjusted for age and sex to determine health category placement. That data can inform program targets and referral decisions. Submaximal predictions come with caveats. Motion, heart rate, measurement errors, and technician variability can skew results. Awareness of these limitations is key to maintaining data integrity. Maximal testing is diagnostic, not always necessary for routine assessments. Absolute contradictions include unstable angina or recent myocardial infarction. ACSM outlines emergency protocols and monitoring standards, including blood pressure thresholds and RPE cutoffs. When conducting cardiorespiratory fitness testing, especially in clinical or population health settings, it's important to recognize that testing isn't a solo task. It demands a multidisciplinary setup, and when that team is functioning well, it directly enhances data quality, participant safety, and ethical integrity. At the core of the testing team is the primary test operator, the person guiding the protocol. This role is critical. They manage pacing, administer instructions, and ensure that each stage of the test is delivered consistently. But their responsibility extends far beyond the technical steps. They are reading the participant's body language, monitoring physiological responses, and deciding whether testing should continue based on established safety criteria. Their presence sets the tone for participant trust and procedural clarity. Then we have support staff. These individuals are responsible for observing and documenting real-time vitals, things like heart rate, blood pressure, respiratory effort, and perceived exertion. They might be recording data manually, troubleshooting equipment, or communicating with participants during recovery phases. But just as importantly, they are there to maintain environmental responsiveness. That means adjusting the room setup if the lighting is disruptive, pausing if the participant shows signs of anxiety, or managing distractions. These actions, though often invisible, help reduce noise in the data and protect participant experience. Every member of the team, regardless of role, should be trained in emergency response procedures. That includes knowing how to recognize signs of cardiac distress or hyperventilation and acting swiftly if a protocol needs to be terminated. They should always be clear on communication pathways. Who speaks first? Who notifies clinical staff? Who documents the event? In high stakes situations, clarity saves time, and time protects lives. This multidisciplinary model isn't just about having enough people, It's about thoughtful coordination. Testing protocols are most effective when each person understands their role, follows standardized procedures, and maintains a shared commitment to participant safety. From a public health standpoint, that collaboration models the kind of systems level thinking we want to promote, one that values consistency, communication, and ethical care. This data does not live in isolation. It connects to broader public health strategies. Surveillance systems like BRFSS and NHANES rely on field-based fitness indicators to track disparities and inform policy decisions. That's how we link individual health to community resilience. Evidence-based assessment isn't just about technique, it's about intent. It's about making sure that the tools we use and the data we collect serve real people in meaningful ways. When we assess cardiorespiratory fitness or any other health related domain, we're not just measuring physiology, we're laying the foundation for personalized care, informed decision making, and responsible program design. What makes this truly impactful is when we apply these assessments through an equity lens. Whether we're working with a young athlete seeking performance insight, an older adult navigating mobility changes, or someone managing chronic conditions like diabetes or heart disease, the American College of Sports Medicine gives us a framework that prioritizes safety, relevance, and accessibility. It's not one size fits all, and that's the strength of evidence based practice. It's flexible enough to adapt to diverse needs while holding firm to scientific standards. It reminds us that assessment is more than data, it's a conversation. It's an opportunity to build trust, align interventions with individual goals, and reinforce the connection between physical activity and long term health. The American College of Sports Medicine gives us the framework. However, it's how we implement that framework in classrooms, clinics, field sites, and policy conversations. That's what defines its real impact. When we prioritize accessibility, when we honor individual context, and when we center ethical decision making in our assessments, we move toward a more responsive and inclusive practice. So, whether you're preparing to conduct a sub-maximal protocol, design an intervention, or teach these principles in your own setting, I encourage you to carry forward this commitment to thoughtful, evidence aligned care, not just for accuracy, but for equity, not just for outcomes, but for impact. Thank you for your time and engagement and for the work you're doing to shape a healthier, more informed public. As we move forward in designing and delivering these assessments, let's hold that purpose close to bring together science and compassion, structure and adaptability, and always people